Today we are starting with the disorders of mood. First we will look at depression in more detail, and then at hypomania and mania, elation of mood. Now the term mood has been used to describe disturbances in emotion or feelings, or the more pervasive term is mood. Sometimes the term affective is used. Again, it is almost synonymous, referring to the subjective feeling of the emotion or feeling, and also the behavioral manifestations that others can see. So affective is a much broader term, and sometimes we say affective psychosis when there are psychotic features like hallucinations or delusions, or affective disorders, which is a much broader term, including the conditions with psychosis and where there are no psychotic features. Fundamentally, the disorder is of mood. So, the mood is either depressed, person feeling sad and low, or it can be elated, patient can be very high. So, the mood can vary, and when it is distressing to the person, or sometimes in hypomania to others, or there is severe functional impairment, as we will discuss, we call it a disorder, or we may need to treat. But at the same time, we have to be aware that in this particular condition, when we say depression, depression is also used in common language, and it can be used in so many different connotations. So, it is very important to be clear when we are talking about it as a disorder or illness, and where we are referring it to it like in common language. Sometimes people say when they have a traumatic event, or particularly when they lose somebody dear to them die, when there is grief, there may be you may say the person is depressed, or it can be a symptom, depression, depressive feelings, affect, which can be a symptom of even found in schizophrenia or organic conditions, or with anxiety. So, it can be a part of the symptoms, or it can be a syndrome with some other features that we say characterize depression, loss of appetite, insomnia, feeling low, crying, and so on. And it can be an illness where the mood change is more pervasive, lasting weeks or sometimes months, and it causes severe impairment in functioning, social, occupational, personal. Person is impaired. So, when we want to go to the level of pathological, when we want to call it a disorder or illness, it is very important to differentiate this from normal reactions. So, we say the mood is pathological if there is no cause, or the causes are insufficient, it is of a long duration lasting for weeks or months, and it is severe, so severe that it causes impairment in functioning. Now, when we look at the epidemiology of depression in particular, looking at the occurrence in populations, we find that depression is fairly common, just depression per se, which can include unipolar depression or chronic depression, and a condition called bipolar mood disorders or bipolar affective psychosis, where you get both mood changes to the depressed side and also to the elated side. There the incidence is not that common. So, you get up to 20% of the population can suffer from a depression at some time in their life, while it is about 1% for bipolar disorder. When we look at people coming for health care, health seeking behavior, when you look at the population in a primary care setting like a ordinary OPD or a general practice, about 10% may be actually suffering from depression, although they may not say they are depressed. They may come with somatic complaints. When we move into the hospital setting, in inpatient setting, about 15% of medical inpatients may be having depression. So, we can see some of the physicians at Jaffna Hospital have now developed a protocol to diagnose depression for their inpatients. When we look at the ratio, sex gender ratio, there is a female predominance for depression, but when we look at the bipolar, it is equal, male and female occurrence is equal. When we look at the occurrence of mania, they say about 5 to 10% of depression can have an episode of mania later on or before. So, that is the classic bipolar disorder. The rest may be only unipolar, only with depressive features. Another interesting feature with depression is that when we look at more severe depressions, psychotic or melancholia as sometimes it is called, major depression is another term that is used in DSM classification. This happens more later in age, towards middle age and later on. Depression is much more common in the working class, the urban population, and in the unemployed, as can be understood because of the stress of unemployment. There may be a difference in the symptom profile or in the manifestation or in the complaints people make when they have depression. In the third world or so called developing world, the low income countries, somatic complaints may predominate, while guilt is said to be more characteristic of the Judeo-Christian cultures, while it is less so in developing world, and there the blame towards outside people may be more common. Now, I mentioned about the functional impairment, and there have been a lot of research and concern, particularly from the economic perspective, about the cost of depression, how much it impacts, how much it costs economically. And they have tried to study this in the concept of the burden of disease, and they use something like the DALI, that is the kind of parameter that is measured by disability adjusted life years. So, the number of life years that are lost due to a particular condition, DALI. So, for depression they have calculated how many years that may be lost. Similarly, for all the diseases, and you will find that depressive disorders comes third, causing about the 4.3% of the burden of diseases overall for all conditions. And it is predicted that by 2020 it may come up to the second, or even it may reach higher levels. So, it may become a very common condition. Already it is very common, and you get all the other conditions mentioned here. Another way of looking at this is very interesting. You can also look at all the disabilities, and about 34% they say are due to behavior related problems, like that includes violence, exploitation, alcoholism, and hypersexuality. But depression is a very common cause of the burden of diseases. Another way that they have looked at it is in the US, looking at the mortality and the morbidity and the costs involved in actually treating the depression, and the actual drug treatment may be very low, but when you look at the cost due to deaths, that is the number of years of productive life that is lost, you may, that is about 17%, and 27% due to absenteeism. People who are depressed may not go to work on a regular basis, or they may not perform when they go to, so that is about 28%. So, the cost altogether in the United States is about 12.4 billion per year, direct cost, and indirect cost is about 31 billion. So, the indirect cost. Now, when we look at the classification of mood disorders in general, this is just a way to understand what is happening, and it is more conceptualized. It is not a hard and fast classification. We can divide the depressions into primary and secondary. So, primary is where the disorder comes on by itself for no obvious cause. So, we are talking about mainly endogenous or due to causes within the body, like changes in the neurotransmitters, maybe due to genetic factors and so on. So, when you look at primary mood disorders, you can have, as we mentioned, unipolar depression, which is much more common, and bipolar, where you get mania and depression at different stages. So, episodes of depression and then episodes of mania, and the depression can be either agitated, where the person is restless and active, and retarded, where they may slow down and you get what is called psychomotor retardation. Unipolar depression can be reactive, like to loss of death of a loved one, or loss of property, or their self-esteem, their dignity, and so on. So, this is reactive to some external event. Then you have secondary depression due to some external cause, due to some environmental event, and it can be due to another mental illness like schizophrenia, alcoholism, dementia, neurotic conditions. With anxiety is very common secondary depression. Schizophrenia, about 25% will develop a depression, and so on. And it can be secondary to physical illness, and these physical illnesses can be endocrinal disorders, central nervous system disorders, and as a side effect of drugs. For example, endocrinal disorders, well known, hypothyroidism, hyperthyroidism, Cushing's syndrome, Addison's disease, and so on. Various illnesses include hepatitis, GPI, and post-influenza due to influenza, and so on. And various other conditions also can cause like Parkinson's disease, post-traumatic after a head injury. So, those are CNS related conditions. Then the drugs like L-DOPA, steroids, the contraceptive pill is well known, and the drugs used for hypertension. So, these are all well known to cause depression, and when we are trying to treat, it may be very important to establish whether these are the causes, and then if sometimes correcting this will improve the depression. When we look at the etiology, depression can be considered from a genetic basis and also environmental basis. Usually you find both are mixed together in different proportions, but there is a definite place for genetic etiology, that is the genes. It is a familial condition, and when you look at first degree relations, that is if one person develops a bipolar disease, the risk in the other person is about 20% developing the illness. When it is bipolar it is 20%, while is unipolar it is about half there, about 10%, but it seems to run in families, although this has not held up in research, but it seems to there is a tendency for the condition to be found in the same family. When we look at the monozygotic dizygotic occurrence, the ratio is 68 to 22%. That is, if one monozygotic twin develops the illness, the risk in the other, the risk that the other twin will develop the illness is 68%. While with dizygotic twins, where the genetic material is like in a sibling, the risk is only 20%. So, very clearly the genetic loading, when the genes are the same, the risk is about 68%. Now, looking also from a genetic point or from a endogenous point of view, we can look at it from a microscopic level or biochemical level particularly, and very clearly the endocrinal system is involved, as we mentioned. Certain endocrinal disorders like hyperthyroidism, Cushing's disease and so on can cause depression, and it is found that when we do blood levels, cortisol levels may be high in depression, and there is a classic test that is sometimes done, what is called the dexamethasone suppression test, and when you give dexamethasone, usually there is a suppression of endogenous secretion of cortisol. But when a person has depression, there may be lack of this suppression. So, that is called a positive DST test, and that may be one way of establishing depression, but it is not always true. Similarly, there is a decreased response to TSH and GH. We find that there is a higher incidence of depression after partus, when there is quite a dramatic change in the endocrine. There is a drastic drop in the estrogen and progesterone levels. Similarly, post-menopausal, after menopause, again there can be a high incidence of depression. So, these are all indications, evidence that the endocrinal system may be involved in depression. But there is also considerable evidence that the cerebral amines, the neurotransmitter systems are involved in depression. They are implicated in depression because of the evidence particularly from the drugs. So, drugs that affect the noradrenaline and serotonin neurotransmission are particularly effective. The drugs so called the SSRI, selective serotonin reuptake inhibitors, are very effective in treating depression. So, the evidence is that serotonin may be involved. Similarly, selective noradrenaline reuptake inhibitors also very effective. The tricyclics and monoamine oxidase inhibitors also affect the serotonin and noradrenaline neurotransmitter system, as we will see later on, and that is again evidence that that cerebral amines may be involved. When we look at various metabolic products of serotonin metabolism, again there may be reduced 5-HIAA in the CSF and some reduction in MHPG in the urine. So, these are suggestive of the involvement of cerebral amines, but there may be a it may be a consequence of changes in the neurotransmitters, the actual depressive condition, and this may be involved being the receptors, up regulation of the receptors. Another mechanism that has been found to be implicated is the circadian rhythms. The sleep awake cycle is particularly affected in the mood disorders. Person is depressed early in the morning, it gets better as the day goes on, and the light dark cycle, the secretion of melatonin is also believed to be involved. So, drugs that affect to address the sleep awake cycle and the melatonin system, aglomeltin for example, have been found to be effective in treating depression. Also they use something called light therapy, expose the person to extra light, and that can be sometimes helpful in treating some of the mood, the depression. The organic causes we have already covered when we looked at the etiology and the classification, and also they have been found that there are certain personality types that predispose to depression. For example, cyclothymic personality, where they have a personality that is cycles or changes from happy go lucky, very elated person to a person who is depressed, who is feeling low and who is out of sorts for a few days, then he is again happy and so on. So, the persons whose mood changes fairly rapidly over weeks or even days. Some people are sub-depressive, they are chronically depressed, they are all the time complaining of various somatic complaints, feeling low, sad, crying, irritable and so on. These are sometimes called sub-depressive personalities, or another term that may be used is dysthymia, if the depression is a little more severe. Now, we were talking about the cerebral amines and how they are implicated in depression, and the evidence is mainly from the drugs that we use to treat depression. Also some drugs that deplete cerebral amines like reserpine can cause depression. So, this is very strong evidence, and this is the reason why we look at the neurotransmitter system in the brain, and drugs have been designed to affect these pathways at different points, and some drugs that were found to be effective have been found to work at different steps in the synthesis and then breakdown of tryptophan, which is then becomes serotonin, and it is broken down in the within the presynaptic cleft by monoamine oxidase inhibitor, monoamine oxidase enzymes. So, drugs that inhibit the enzyme, which increases the level of serotonin and also noradrenaline, are effective antidepressants or drugs that are used in the treatment of depression. Similarly, drugs that block the reuptake of serotonin and noradrenaline, so that you get increased levels in the synaptic cleft, are also very effective antidepressants. So, these drugs are working by increasing the amount of neurotransmitters, and one of the most effective drugs are the SSRIs, serotonin reuptake inhibitors. Similarly, noradrenaline reuptake inhibitors, or both, working on both systems. Then we have various drugs that work after the neurotransmitter has crossed the synaptic cleft in the postsynaptic, particularly at the receptor levels. So, we find that there is a lot of evidence, I will come to the next slide also, that the drugs are particularly involved, the drugs that are effective for depression involve these neurotransmitter systems, particularly serotonin, noradrenaline, and to some extent dopamine. So, particularly it involves a reuptake inhibition, and the drugs like the SSRIs, fluoxetine and sertraline, the common popular ones, and also the other like citalopram, are all SSRIs. So, they block the reuptake of serotonin back, so that you get more amounts of 5-HT which can work on the receptors and the transmission can go along. Similarly, noradrenaline blockers like the classical tricyclics or the heterocyclics, monoamine oxidase inhibitors, as I mentioned, which block the breakdown of these neurotransmitters, and venlafaxine. So, and there are some novel drugs like mirtazapine, which works on the alpha receptors, presynaptic receptors. So, these are all evidence that these neurotransmitters may be involved in depression. So, when we look at this the evidence and look at how these amines may be working in to cause depression, the hypothesis says that the neurotransmitters that are involved. So, when we use drugs that increase the level of neurotransmitters, like it increases the level of serotonin, we get increased levels of serotonin, the hormone, which may then bind to the receptors and work through the second messenger, cyclic AMP, to increase the second messenger, which works on the genes. And the genes, you may get a change where if I can read from the messenger protein kinase activates the transcription factors by phosphorylating them, causing a decreased receptor synthesis or down regulation. So, the receptors may be down regulated which may be the actual mechanism of action. These actions can be also cause increase in protein synthesis, particularly BDNF, brain derived neurotropic factors or other proteins which may be involved in the actual way that the antidepressants work. So, the antidepressants take some time to work, and so we have to explain it by a mechanism that takes some time to show, not direct increase in the neurotransmitters only. There may be a change in the genetic level. Now, when we look at the environmental causes, the external environmental causes, there are many causes that have been identified by research. They have found that several factors may be directly involved. One factor that has been identified is maternal deprivation or separations, losses in early life. As a child, person may have experienced, and that may predispose them to develop depression later in life when they are faced with a similar life situation. For example, their partner is about to go or leave, or who due to some conflict, marital conflict. So, the person may be associated, or it may trigger things that happen in their past, in their childhood. Sometimes there is a condition they describe as learned helplessness. Which where the person becomes helpless and feels that nobody is there to help them, and this also again from childhood they have faced several situations where there was nobody to help them, and they seem to be at the mercy of whatever happens outside. Then threatening life events of particularly of a traumatic nature in the past 6 months can lead to a depression, or there is a robbery, or they have faced some severe rape, or anything that is threatening to their life. Another factor that has been very clearly shown is that people who become depressed lack a confiding relationship. So, they are within their friends and their peer group, they do not have anyone they can confide in. Their relationships tend to be very superficial. They lack social support. They feel alone, isolated. Another interesting factor is loss of the mother before they were 11 years old. That has come up to be statistically significant. And of course, the death of a loved one, what we call grief reaction, is almost like a classical prototype of depression. So, we go on now to the symptoms of depression, the manifestations, and looking at the more severe type of depression, psychotic or endogenous type of depression as sometimes it is called. Some of the characteristic features is there should be a persistent lowering of mood that is longer than 2 weeks. So, it is not a momentary, person does not become depressed due to some event in their life like a bad results from the exam and then they recover within a day or two. So, the persistent lowering of mood, there sadness, crying spells, loss of interest and pleasure, loss of pleasure, sometimes called anhedonia. Nothing seems to make them happy, there is no enjoyment in life. Loss of reactivity to circumstances. So, if something happy happens, something pleasant, somebody congratulates them or compliments them, it does not make any difference, they continue to feel depressed. Diurnal changes in the daily cycle, as I mentioned earlier. So, they are worse in the morning, they get up feeling very depressed and there is a higher risk of suicide in the early morning. Loss of appetite and loss of weight, which are sometimes called vegetative or biological symptoms. Insomnia, early morning awakening, as we mentioned already in the diurnal rhythm. Loss of energy and fatigue are very common. Changes in menstruation and loss of libido. So, these are altogether called biological symptoms or vegetative symptoms. As I mentioned, depression can be either agitated, where the person is restless and pacing and unable to feel relaxed, or retarded. There is a severe psychomotor retardation, person becomes slowed down, their talk is slow, they move very slowly, they may get bedridden and so on. Loss of concentration, loss of memory, loss of attention, sometimes called pseudo dementia or can be mistaken for a early dementia in the elderly. Feeling of helplessness, hopelessness and pessimism are characteristic changes in the perspective of the person. So, he feels that it's hopeless, the future, there is nothing in the future for them, that they are worthless, that they are not able to do anything, nobody, they are not able to help anybody, nobody looks to them for help. They feel guilty that they have done something wrong, which is much more common in the western countries, but again it is a very important sign. Then we have the cognitive triad of Beck, which is a negative view of themselves, of the world and of the future, a kind of pessimism about the future. Nihilistic delusions, that is delusions that of a very negative nature, that their abdominal gut is wasting away, or that they have developed some cancer and they are dying, and they may get hallucinations which are congruent with the mood. So, they get auditory hallucinations accusing them of doing something wrong, of people crying, of dead people, all of a negative nature. And very important, very important to always consider and to assess is a suicidal risk. So, people in depression can develop suicidal ideas and they may attempt suicide and sometimes they may succeed. So, it is very important to look for suicidal ideation in a person who is depressed and they say that people who commit suicide, depression is the leading cause. So, it is very important to rule out suicidal ideas when you are dealing with a depressed patient. So, this is the same thing in a picturesque form, what we have already covered. So, depressed mood lasting more than 2 weeks, loss of interest, anhedonia, loss of weight, loss of appetite, sleep disturbance is very common, early morning awakening and inability to sleep, agitation or retardation. So, there is changes in the motor behavior, fatigue, loss of energy, feelings of worthlessness, hopelessness, helplessness and so on, and executive dysfunction and inability to carry out activities, loss of concentration, attention and so on, and very important, suicidal ideation. So, these are all characteristic features of depression. Now, earlier I mentioned something called reactive or neurotic depression. This is not a established diagnostic category, but it is a concept worth mentioning here, because it is a concept where we are talking about depression due to some external event that causes a reaction. So, this is an old concept which is no longer accepted, but it is worth knowing about it, and some conditions we can understand if we look at it from this perspective. So, they say that it is more common in the young adults and is usually reactive to some stress. So, what is important here is that in the management, if you can remove the stress, the person may recover. There may be signs of anxiety, insomnia, and as we mentioned, the loss of a close relation of a within the immediate family is one very important cause of depression, grief reaction. So, just to give you an idea, we just take the example like a prototype of grief, and there is normal grief, that is when a person close to a loved one or a member of the family dies, it is very normal for a person to feel some grief, to have a depressed mood, and that should not be considered abnormal, and usually they give around 6 months for this, and it is sometimes divided into different phases, and the first phase is so called the stun phase, which may last from few hours to days. When they hear the news, they may be sort of in shock, or they may not be able to take it in, they may not completely accept that the person has died. Then we get the typical mourning phase, which goes on for months, and that is the typical grief that we all know of, where there is distress, pangs of crying, autonomic symptoms like indigestion, choking, lack of appetite. These symptoms may be increased during anniversaries. So, in particular in the Tamil culture, the 31st or the month and the yearly, you may get some of the symptoms coming back, and there may be an increase in morbidity and mortality, increased incidence of heart attacks and so on, due to the grief reaction, because of the effect on the sympathetic nervous system and other physical systems. So, there may be preoccupation with the deceased person, searching for them, feeling that they are present in the house or sitting in the normal chair, that sometimes they may hear them calling them, so on. They may keep things that of the dead person as it was, keep the house, the room the same way, keep their belongings, sometimes called mummification when it is of a severe nature, and they may not change that for months or years even. And there may be guilt that they did something or they caused the death by not taking appropriate action. They did not take them to hospital in time, or the person asked for something and they did not give it, they were not loving. So, this kind of guilt is very common, as well as hostility. They may blame others, they may blame the hospital staff for not treating properly or not giving the right injection or not listening to the complaints and so on. So, you may get a hostile reaction from the relations who are in grief, and we expect the whole grief reaction to resolve within 6 months. Usually by 6 months, they start accepting the death, they start readjusting their life, they learn to live without the person, and slowly they come to terms with the reality. So, this is called working through, a process that you can help through counseling, grief counseling or bereavement counseling, adequate support, and our culture also has various rituals and ceremonies that may help the person to come to terms with the death, to loosen the ties one by one. So, this is called the grief work. Now, if the grief continues for long period, longer than expected, so this can vary from culture to culture, but generally we say about 6 months, but it can be different for different cultures. So, this if it gets prolonged, we call it atypical or pathological grief, or if it is very excessive, person becomes suicidal, or the guilt is of a delusional nature or very severe, there is intense hostility, the person starts identifying his own physical symptoms with the symptoms of the person who passed away, becomes very severe, then we may consider it a pathological grief, and then we may need to intervene. They may need treatment, they may need support, they may need some medical treatment. So, that is a condition called prolonged grief. Now, there is another condition which is sometimes called atypical depression or mass depression, where the symptoms are not characteristic what we find in the normal depressive condition, and this may be variation depending on the person's personality, background, culture and so on, and you may get a hypochondriacal picture where somatic complaints may predominate, particularly in our part of the world. There may be hysterical conversion where person may develop a paralysis, or sometimes they may lose their voice or so on, and you find the person is actually depressed due to some stress or some traumatic event. Obsessive features may predominate, or it may be comorbid associated with the depression. As we said already, somatization, pseudo-dementia, loss of concentration, memory, attention, sometimes can lead to a misdiagnosis, particularly in the elderly, of a dementing process, while if you can make the correct diagnosis and treat, the person will recover. So, very important differential diagnosis in the elderly. Anxiety is sometimes very difficult to differentiate or to distinguish which is primary or which is more important, and usually it is a mixed picture. So, you get what is sometimes called mixed anxiety depression, where both conditions seem to exist together. Sometimes you get behavioral changes, for example, shoplifting in females, and sometimes this has been used as a defense in court to say the person was depressed and that is why they lifted something without their knowledge, while alcoholism is sometimes secondary to depression, and you find that in some males. And another way that depression can sometimes present in some people, not the common way, there can be an increase in appetite. Person may overeat. Sometimes person may go into binge eating like a bulimia or that picture, or their sleep also can be increased, hyposomnia. So, this is an atypical depression, and they say this responds sometimes better to the monoamine oxidase inhibitors, may be worth using that as the first line of treatment. Now, as I mentioned, depression and anxiety can coexist, very common. In fact, very often you find that both are present. Sometimes it's the clinical task is to sort out which is more, or which is predominant, or which is primary to treat, but often it is mixed together. And you find that various conditions like post traumatic stress disorder, PTSD, there is a high incidence of depression, 48% have depression, panic disorder, generalized anxiety disorder, obsessive compulsive disorder, and social anxiety, all associated with depression. So, the coexistence of depression with these conditions is very common. In fact, it is more common than we may find in depression alone, pure depression. Now, we come to the other condition, the other pole of mood disorders, which is not that common. We already said that depression is the common condition that is fairly common even in the general population, maybe up to 20%, but some develop what we call a bipolar. So, you get two different poles, and while the patient can be depressed, the person can be also elated. So, there is a person's elevation in mood, and some of the symptoms of elevated mood are over talkativeness and restlessness, which are very characteristic. Person keeps on talking, they are not able to stop. There may be flight of ideas from one topic to another topic very quickly. They may have grandiose delusions, feel that they are somebody very important, or that they are God, or that they are the politically very important and they are very powerful. They may have a lot of plans. They want to do this and that, and they may start various things, spend a lot of money, take loans, and get into all kinds of trouble because of this increase in mania and the hypomanic stage. And they may get into a lot of debt also. They may take loans. They may spend a lot of money. They may overspend and buy things for others and be very generous with their money. And there may be an increase in libido, so that there is risk of sexual promiscuity, and they may get into all kinds of relationships which they may regret later. So, these are some of the characteristic symptoms of hypomania. Sometimes particularly when they are blocked or they are not able to achieve some of the ideas, they may be irritable, they may get angry, they may become hostile. So, it is very important to remember, sometimes we may not get the happy elated person, you may get an irritable person. So, again using Stahl's psychopharmacology book, these are the illustrations of same symptoms in picture. So, you can just to show it in picture form. So, elated, irritable mood, and then the grandiosity, increased activities, risk taking, they may get into accidents, lack of sleep, lack of concentration and distractibility, going from one task to another task, over talkative, non-stop talking, and flight of ideas. So, this is just to give you a idea of different brain regions that may be involved in the various symptoms that we find both in depression and hypomania. So, it may be the same brain region, while in depression it may be due to a change in a different direction, and it may be the opposite direction in mania. So, if depression is due to some hyperactivity or reduction in say neurotransmission or so on, in hypomania it may be the opposite. Evidence is not established, but these are believed to be the regions, and you find that the mania is, we are given it in red, and the depressed features characteristics are given in blue. So, the prefrontal lobe and the thalamus and so on, hypothalamic area, all this may be involved in the different symptoms that we see in hypomania and depression. Right, now the management or the treatment of mood disorders. Mainly we will be looking at the treatment of depression because it is more common, but I will mention the treatment of hypomania and mania at the same time. Hypomania is a slightly milder form of mania. So, first step or decision is whether to admit the patient, and particularly if there is a suicidal risk or there is severe self neglect, or the person is going into sometimes called depressive stupor of due to severe psychomotor retardation, they are not eating, drinking, they are bedridden, they may need to be admitted for treatment. Or if particularly in a hypomanic state, there is no insight, they are at risk of getting into all kinds of trouble or doing things that they may regret later, we may need to admit them. Then when we look at the drugs of choice for treating mood disorders, for depression, usually we use, as we said, some other drugs that block the neurotransmitter reuptake system, the reuptake of serotonin and noradrenaline in particular. So, we have drugs, the older drugs, the tricyclic antidepressants, monoamine oxidase reuptake inhibitors like imipramine and amitriptyline, which work on both systems, serotonin and noradrenaline, while the newer generation, the newer drugs can be more selective. So, we have the selective serotonin reuptake inhibitors, then we have the ones that are selective for the noradrenaline reuptake, we have others that work at other sites like the presynaptic receptors and so on, and then we have the monoamine oxidase inhibitors that prevent the breakdown or stop the breakdown of the neurotransmitters and may be more effective in some forms of depression like atypical depression or as a second line when these drugs are not working. So, the drugs that have been used, particularly moclobemide, which is a reversible monoamine oxidase inhibitor of the A type. The earlier monoamine oxidase causes various types of reactions which can be fatal. So, it is very important to be very cautious in using the monoamine oxidase inhibitors. Now, if these drugs are not proving effective or the depression is of a severe nature, suicidal, depressive stupor and so on, we may consider ECT, and ECT is particularly effective for severe depression and the results are very good. ECT, almost 80% of patients may recover. So, depression is probably the indication for ECT. Now, there is a role for mood stabilizers both in mania and in also depression to prevent a recurrence or the occurrence of a manic episode. And we use drugs like lithium, which is very effective both for treating mania and hypomania to reduce the elated mood and also for long term maintenance to prevent a relapse or recurrence of bipolar disorder. And usually when we are treating mania, we may go for a slightly higher blood level and maintenance can be at a slightly lower level, so from 0.4 to 0.8. The importance of serum levels, as we would have studied in psychopharmacology, is that lithium is a very toxic and there is only a very narrow difference between the therapeutic and the toxic levels. So, you have to maintain the blood levels of lithium within a very narrow margin between 1 and 0.4 really, and if it goes above 1, particularly up to 2 and above that, it can be fatal. So, it is very important to be very cautious about using lithium, but very effective. Alternative drugs are carbamazepine, valproate, or nowadays even lamotrigine is used. These are also very good mood stabilizers. The antipsychotics have been used in the treatment of mania while waiting for the effect. Now, lithium may take up to 10 days or more to start working. So, you give something to slow them down, to calm them, and drugs like olanzapine, quetiapine, chlorpromazine, haloperidol have been all used in the treatment of hypomania and mania, very effective, and initially we have to start with some of these antipsychotics. They can be also used in agitated depression to calm them down for sleep purposes, or when there is a psychotic aspect to the depression. Very effective is cognitive behavior therapy for the treatment of depression. In fact, the claim is that it is superior to the drugs, it is more effective than the antidepressants. So, cognitive behavior therapy can be done with a clinical psychologist or even doctors who are trained in CBT, and counseling for reactive depression or grief, as we mentioned already. So, very important aspect of the whole management is the correct choice of drugs and looking for side effects and finding the correct drug to treat. Now, when we look at the course of the mood disorders, when we look at the bipolar disorders, as we said, we get different episodes. So, the initial episode could have been a hypomanic one, where they were elated, and it can last for a few weeks or months, maybe up to 6 months, and then they may be normal, so called euthymic, where they are neither depressed or hypomanic, they are normal. Then they may go into a depressed phase, the mood goes down, low mood, and that may again last for 6 months, and then again they may recover and be normal, euthymic. For months, years, they may be euthymic, and then again they may get another depression, a recurrence, a relapse, another episode of depression, again they may recover, but they may go directly into a hypomania or mania. So, there is always the risk of this happening, sometimes called a switch, straight from depression they go into hypomania or in manic when it becomes very severe at the top of the curve, and then they may be normal for some time. They say some of these episodes may increase as they get older, but this is the general life history of a person with bipolar disorder, different episodes of hypomania or depression. In unipolar depression, you get only the depressed, so only the ones in the low, they do not get any hypomanic attacks, and then there is a picture of chronic depression where they are depressed for years. So, finally, the prognosis, and they say around 5% of the depressed patients may become manic. So, the risk is not that high, but few, particularly they may go into hypomania or mania when you treat with antidepressants. The older tricyclics are particularly notorious. So, be careful when you use antidepressant treatment. 20 to 30% of depressions have a chronic course, it keeps to going on. So, they may be what we call the depressed kind of personality or the subdepressives. They are sometimes called dysthymia. So, less severity, but persistent change, lowering of mood that goes on for years and very resistant to treatment. 15% of those with the depression may commit suicide. So, very important to assess the risk, take precaution, admit if necessary, and be always aware that people with, particularly people with suicidal ideation or so on, can be depressed, and if you treat the depression, they may recover. So, one way of managing suicidal ideation is to be able to identify depression and treat. So, very important is to assess the suicidal risk. Okay, thank you very much.